Hello, and thank you for joining us for today's hybrid education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Senior Moments or Something Else, Understanding Dementia and Alzheimer's Disease. If this is your first time joining us, CSC South Bay's mission is to uplift and strengthen people impacted by cancer by providing support, fostering compassionate communities, and breaking down barriers to care. Our vision is that everyone impacted by cancer receives the support they want and need throughout their experience. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join our community, please visit our website at cscsouthbay.org. Before I introduce today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. Please feel free to enter any general questions into the chat function found at the bottom of the Zoom window at any time. Without further ado, I'll introduce our workshop speaker. David Hart, Ph.D., LPCC, is a professor and licensed clinical mental health counselor with over 20 years of experience working with caregivers, people living with dementia, and their families. Always Best Care Senior Services is a trusted family-owned and operated home care company with a passion for supporting families along their caregiving journey. Thank you so much, Dr. Hart, for being here with us today. You're currently muted.
Yeah, I was looking for the unmute button. I was just sharing with folks here in the room that that picture is about 10 years old. So I need to get you a new picture, Rebecca. Hello, everybody. My name is Dr. David Hart, and just, my camera is here, but I also have an audience out here. So I'm going to try to speak to both the camera and to the audience. Thank you for having me again. I always enjoy my time here at the Cancer Support Community. I know you all are doing such wonderful and valuable work, and I'm very happy to be a part of it. And so Rebecca asked me to talk today on a passion of my own and where I have some clinical specialization. So just to introduce myself just a little bit more, I have been practicing psychotherapy for the last 20 years or so, and I specifically work with older adults, but even more specifically, I work with people with dementia and their care partners. I've been doing this work, like I said, for about 20 years. But I think what says more about my experience is that I was also a family caregiver. My grandmother was diagnosed with Alzheimer's disease when I was 15 years old. And so that was like 1994. I know I'm dating myself a little bit, 1993, 1994. And we had never heard of the word Alzheimer's disease. That was something very new to us. The word that we were probably, and maybe you're probably more familiar with, is like senility, right? Or something like this. And so that was like pre-internet time. So we really had zero information about what the disease was, what to expect as it progressed, and most importantly, how to be most helpful to my grandmother. I will say this, one of the reasons that I do this work and am committed to doing this work for my lifetime is that although our hearts were always in the right place, we often didn't know what we were doing anyway, right? So what I've tried to do in my career is to help folks to align your hearts and also your minds so that you have the best possible information to complement your big heart, right? And to do this sometimes very difficult and challenging work of caring for a person with Alzheimer's or related dementia. And I know that's primarily why I'm here, is to give you somewhat of an introduction, right? So that you understand, what is this disease? What is Alzheimer's disease, and how is it related to dementia? How are they similar, and what makes them different? And also, even beyond that, I mean, as we age, we all start to experience what scientists call age-related cognitive decline. And believe it or not, that age-related cognitive decline starts to happen at around age 35 or 40, right? Because that's for most of us at age 40, at between 35 and 40, that's midlife for most of us, statistically speaking. So we start to see we've kind of hit the hill, the top of the hill, and we start maybe dropping down a little bit. But that's normal. And so I'm going to ask you a few simple questions, right? And you can, for those of you at home, you can raise your hand. I can't really see you, but I can see these folks. To help us normalize this age-related cognitive decline. So, how many of you sometimes, or even oftentimes, forget the names of people that you just met? Raise your hand if that's true for you. Sometimes or oftentimes, right? Yeah. I mean, I think for most of, I see a lot of hands going up there and some smiling faces. For most of us, when we meet somebody for the first time and we're maybe in a social situation, we may not remember their name, so we might have to ask, right? So that's pretty normal. How many of you from time to time or oftentimes walk into a room and forget what you're doing there? Okay, I'm seeing us, I see some hands up, right? And some laughter because it's true, right? We're easily distracted as we age. And I'll say more about that later. But yeah, we walk into a space like, what in the heck am I doing here? But most of us have the ability, right, and the capability of refreshing our memory, right? We go back to where we had the memory and then, oh, that's right. That's what I was doing here. And how many of you from time to time or oftentimes misplace your keys or your phone or your wallet, right? Yeah. Yeah, most of us are having these experiences and it's absolutely normal. So I want to normalize that. And so we have the capacity, if we're healthy agers, right? If our brains are relatively intact, we have the ability to create strategies, to adopt strategies that help us to remember, right? So for instance, if I want to remember somebody's name, I could use a strategy for that, right? And I might use an association strategy, or I might use a visualization strategy, or I might use alliteration. But there are different ways that I might go about doing that. For instance, if I needed to remember all of your names here, the first thing let me just ask, what's your first name, love? Agnes. Okay, Agnes, my name is Dave. Nice to meet you. What's your name? Say that again. Elna. Elna. Oh, Elna. Elna.
And then people call me just L because they forget my name. It's a four-letter name, but they just call me L.
Elna. Elna. Okay, so I have Elna and Agnes. Okay. What's your first name, love?
Vila.
Ella Vila? Oh, you all are giving me some hard ones today. You are Ella Vila. Oh, that's a beautiful name. That's a beautiful name. All three of you have beautiful names. So Ella Vila, Elna, and Agnes. Ella Vila, Elna, and Agnes. Do you see what I'm doing here? Right? I'm repeating, first of all, I'm repeating the name. I'm making sure that I understand the name. So you're seeing that I'm really setting an intention to remember their names. And sir, what is your name? Roy? Ron. Ron. R-O-N. Ron. Okay, oh my gosh, my heart is pumping here. I'm really struggling. All right, Ron, Ella Vila, Elna, and Agnes. Ooh. All right. Okay, Ella Vila and Elna. Those are the two that I can't associate yet. But Agnes, I'm associating with God. Mary, Mother of Agnes is what I'm thinking. And Ron, that's a unique name, but I don't have something to associate with, but it's a three-letter word, so I'm just gonna focus on R-O-N. R-O-N. Maybe I'll say Ron like run. But do you see what I'm doing here? And then Ella Vila. Oh, I'm thinking of a beautiful home with a view. Right? A home with a view. Okay. So notice my strategies here, and I'm going off base a little bit, but off track, what I want you to hear is that for those of us with relatively intact brains, we can create strategies that help us to remember. We can place our wallet and our purse in the same place time after time. If we want to remember where we parked our car, we can note it down on a piece of paper or take a picture. But our brains are capable of rehearsing strategies and following through. A person with dementia can no longer remember to remember. The strategies don't work, right? Because the function of memory is becoming more and more impaired. So what I want you to know, there are different types of memory, and I'm sort of jumping into this because I think it's relevant at this point to give you context. Now, what was I saying? Oh, that's what I was saying. See, there's my senior moment. I remember I had to go back to what was I thinking? Here's what I was thinking. What I just did with you in terms of remembering your names, that's a type of memory that we call working memory. Working memory is seconds to maybe a minute, minute and a half. Okay. Now, can you imagine, for those of us who are aging, it's our working memory that's most impaired. It's the memory that's the seconds to minutes. What I just asked you, right? Can you remember the name of somebody that you just met? That's working memory. If I want to transition that information into something that I remember more long-term, let's say minutes to hours, that's short-term memory. And in order for me to take that information in working memory to short-term memory, I had to create a strategy. I had to adopt a strategy. And my strategy was rehearsal, association, and repetition. Now you all can test me at the end of this lecture. If I'm able to remember their names at the end of this lecture, then I have successfully transmitted that information from working memory into short-term memory. Now, once I leave this building and I leave this experience, will I be able to remember your names? Probably not, unless I use another strategy, right? And that strategy might be I take a picture of you and I look at your picture every day to help me to rehearse your name. But do you see here, remembering your name isn't necessarily important. And that's the thing that we all have to sort of adjust to and adapt to, is that we've got to pick and choose what's important to us. We can't expect our memories to work as well as they did when we were kiddos, or as teenagers, or in our early 20s and 30s. Just like our bodies, our minds change, our memories change as well. And so if you want to have a stronger memory, then you have to work at it. Right? Does that make sense? Good. I'm going to move now. I got to get to a slide, I guess. I'll get to a slide, maybe not just my name. Let's see. There we go. All right, so here's what we're going to do. We'll talk about the differences between Alzheimer's, age-related cognitive decline, and dementia. We'll talk about lifestyle factors that may reduce your risk for developing dementia over time. We'll talk about the different causes of dementia and how it's treated. And then we'll also address caregiver concerns and how to be helpful to, just in terms of caregiver self-care. So those are some things that we'll do today. So there is this transition from, normal aging potentially to dementia. And so, our brain is responsible for more than just what we remember, right? Our brain is responsible for everything, ultimately. It is the command center of everything that we do. But in terms of sort of age or brain fitness, right? How do we exercise our minds? And what can we do to strengthen our brains? We're thinking about, language skills. We're thinking about problem solving. We're thinking about critical thinking. We're engaging in strategy, games of strategy, like chess or even Scrabble, for instance. Scrabble is really not a word game. It's really a game of strategy. We're also engaging in visual spatial activities. So what I want you to know is that the brain is not just memory, and that we don't have to focus on solely remembering stuff. We can focus in other mind strengthening, mind broadening activities too. And in fact, if we were thinking about, there's a four-pronged approach that I'll get to at some point in the presentation, a four-pronged approach to reducing one's risk for developing dementia. And those four prongs include diet, exercise, social connectivity, and cognitive fitness. Out of those four prongs of potentially reducing risk for developing dementia, I would say that cognitive fitness is the least effective. And that's just based on what the research tells us. Right? Probably the two most, actually, all three in conjunction: what you eat, how you move, and who you connect to. Those are the most important. Those are the most impactful strategies for reducing risk for developing dementia, but I'll get more into that in a moment. So as we age, it takes us longer to process new information. It takes more effort to learn and store information. I will tell you, and this is, most older adults don't believe me, but the number one strategy to improve your memory, can anybody guess? Number one strategy to improve your memory? Sleep. Any other ideas?
Reduce sugar.
Reduce your sugar. Diet. All of those are absolutely accurate and correct. But the number one strategy to improve your memory is to practice the art of concentration and to limit distractions in your life. As we age, we're more susceptible to distraction, which essentially averts concentration. Right? So we have to strengthen our capacity to concentrate. Actually, this is what is happening now to our kids, right? What are they distracted by? Their phones. Their phones. And so what's happening is they're losing the art. They're losing the ability to concentrate because they're so easily distracted by technology. This is true too for all of us. Can you imagine? Would you be able to concentrate on what I'm saying if a heavy metal band was playing next door? No, right? So we're much more susceptible to distraction. For instance, earlier today, I was saying there's so much commotion in this office. There were people, in the hallways, and there's stuff happening and all this stuff. And it distracted me. I got all kind of like, what am I doing? And where is my center? And I had to refocus my attention. So it just becomes more challenging as we age. So practice the art of concentration and limiting distraction, and your memory, if you have a relatively functional brain, meaning that there's no impairment happening, that you will see your memory improve. So we have a delay in recalling information, and that's that, like, the word is on the tip of your tongue, but you can't quite access it. We've all experienced that. And then 2 hours later, you're like, oh, there it is. I got it. I found it. That's absolutely normal, right? What's not normal is forgetting words completely, right? Not having access to language. That's not normal. We might struggle to find a word, but we're going to be able to describe what that word is. We'll pick words around it, right? For instance, if I'm trying to describe this remote control and I can't find the word, I'm still going to be able to say, that thing that turns the TV on? I can't find the word for the actual thing, but I can tell you all about it. That's normal. A person with dementia or Alzheimer's disease, they're not going to be able to tell you all about it, because not only is the word gone, but so is the contextual words. Does that make sense to everyone? Yeah. Okay. All right. Also, it's harder to multitask as we age. We don't ever really multitask. We're basically switching between focuses, right? So we're not actually spinning 3 plates at the same time. They're spinning and we're just moving between them. Well, that process becomes a little bit more fragmented, right? Okay, so let's just talk about the continuum then, and I'm going to use my own example. You'll see here normal aging, MCI, which is mild, it stands for mild cognitive impairment. And mild cognitive impairment is the borderland between normal aging and developing dementia or Alzheimer's disease. Okay, so I'm going to give you an example. So I'm driving my car. I drive a VW Bug. So you can imagine me in my VW Bug. And I'm driving to the South Bay Galleria. Is that what it's called? No, not the South Bay Galleria. Del Amo Fashion Center. I'm driving to Del Amo Fashion Center, and I love to shop at Nordstrom. So I'm gonna park my car at Nordstrom. And if I have a healthy, functioning brain, I'm going to say, okay, here I am. I'm parked at the front of Nordstrom. I'm in aisle A, and I'm going to walk in and do my shopping, and it'll be very easy for me to find my car later. Okay. If I have, sometimes I'm forgetful, and I really need to focus on where I parked my car, then I'm going to maybe take a picture, right? So that I can look on my phone, or maybe I'm going to write it down on my phone just in case. Front of Nordstrom, aisle A. Okay. But I'm remembering well enough to know that sometimes I'm forgetful and I need to do something extra so that I am sure to remember. Okay. That's mild cognitive impairment, not yet quite dementia. Okay. A person with dementia, though, right, who is full blown in dementia, is going to be looking for their car at JCPenney, right? There's no visual spatial ability or a process or a strategy to remember where they are, right? Because that insight is lacking. So do you see then these qualitative differences between normal, maybe somewhere in the middle, maybe increased risk, and then fully diagnosed with dementia? Okay. And of course, every individual is different. So, the way symptoms show up for each patient is different. and it also depends on which dementia they're diagnosed with. And so I think we need to get into that here pretty quickly. Actually, let's see. Let's go there now. So the main question is often, what is dementia and how is it related to Alzheimer's? Because they're often used interchangeably. So was my task today. Okay. So dementia is an umbrella term that essentially, how do I want to say this? Let me say this in a different way. I'll say it in a different way, in a better way. Dementia is not a disease. That's the first thing that you need to know. Dementia is considered a clinical syndrome. And all that essentially is a cluster of symptoms. So if a patient exhibits a cluster of symptoms that include memory loss, right? And one or more additional cognitive impairments. And those cognitive impairments, we talked about them earlier, could be visual spatial skills, executive functioning, orientation to time and place, ability to strategize, impairment of language. Okay. So in order to be described as having dementia, the patient has to exhibit memory impairment, impairment of one or more additional cognitive functions, and those impairments together affect the patient's activities of daily living. In other words, they're no longer able to do what they once were able to do. For my grandmother, okay, let's test this. Okay. For my grandmother, she exhibited with first criteria, memory loss. How did she meet that? Well, we go into her home and we would notice that there were burnt pots on the stove. Okay. That indicated that her short-term memory was impaired. She was forgetting that the stove was on. So she meets the criteria for memory impairment. Okay. Now we're looking at one or more cognitive impairments. So what were those? First one, executive functioning. I noticed that she was no longer able to balance her checkbook. And I noticed that because when she would pull out her checkbook to write a checkbook or to write a check, and then she'd flip back to the check register, it was nothing more than scribbles. Right? So now we've got memory impairment, impairment of executive functioning. The other one is that she had impaired judgment. The capacity to judge what is good or not good, or what is healthy or unhealthy, or what makes sense or doesn't make sense. So what she was doing is she was subscribing through Publishers Clearinghouse to, I'm not kidding, dozens, if not hundreds of magazine subscriptions. So now we have impairment of memory, impairment of executive function, impairment of judgment. Now we have to ask, does that affect her activities of daily living? Yes, she was no longer able to spend her money wisely. She was no longer able to cook safely, right? So yes, so she meets the criteria for being described as having dementia. Now, what is the obvious question that we would ask next? If she's described as having dementia, then we were wondering what?
You take care of yourself.
That's a good question. Yeah, can she take care of herself? Or answer. The next question, and this is what I'm encouraging you all to do. The next question is, what's causing it? What's causing these symptoms? Right? So if somebody says that they have pain, What's the next question? What's causing the pain? If somebody says that they have dementia, the next question, or if somebody says, I have memory loss, right? I'm making poor judgments about my checkbook. I'm have 100 subscriptions through Publishers Clearinghouse. The next question, well, what's causing that? And that's the question. So anytime for those of you out there, and you go to the doctor and they tell you, well, I think you have dementia, your next question immediately should be, well, what's causing it, doc? Because what is the number one cause of dementia? The number one cause of dementia is Alzheimer's disease. So that's why they're used so interchangeably. The number one cause of dementia is Alzheimer's disease. Right? That's really important for you all to understand. And so you can't look in the brain and see dementia, but you can look in the brain and see Alzheimer's disease. You can look in the brain and see frontotemporal dementia. You can look in the brain and see Lewy body, right? You can look in the brain and see traumatic brain injury. These are all causes of dementia, right? So dementia is the symptom, the cluster of symptoms that we see as family members or as clinicians or as friends. But the next question is, well, what's causing it? Because there are some irreversible and then potentially reversible causes of dementia. Now, most of the time, in 85 to 95% of all of the cases, dementia cases, it's an irreversible type of dementia. But there are reversible causes of dementia, including, most frequently for older adults, medication side effects. Medication side effects can cause symptoms, including memory impairment, cognitive impairment, and loss of functioning. Another big one for older adults is dehydration. Trust me when I tell you, older adults, for whatever reason, are not drinking enough fluid. I can even say at my age, I'm not drinking enough fluid. I need to do better. I need to do better. We all can do better. But it causes dehydration. Have you ever interacted with somebody who's dehydrated? Right? Yeah. They are oftentimes hallucinating. They can't remember their name. They can't remember where they live. They're no longer able to function, right? So it is a significant impairment. In addition, metabolic issues, like if you have an imbalance of electrolytes, for instance, that can also cause symptoms of dementia. Okay. But for the most part, if you're diagnosed or described as having dementia, you likely have the Alzheimer's type because it represents about 55% to 75% of all dementia cases. Okay. And there's about 6 million Americans currently diagnosed with Alzheimer's type dementia. But for those of you who know folks that are caring for people with dementia, there are other types that are very different from the Alzheimer's type. Frontotemporal dementia, this has become very more well known recently because Bruce Willis, right, was diagnosed with frontotemporal dementia. Well, it's very different from the Alzheimer's type because it's generally young onset. We're talking about mid-50s, early to mid-50s, sometimes even before that. It's often also a very rapidly progressing dementia. So Alzheimer's type dementia, we're looking anywhere between 8 to 10 years between diagnosis and death. Frontotemporal dementia, we're looking anywhere between 4 and 6 years. So it's a much more rapidly progressing dementia. It also looks very different because it is impairing the centers of the brain that are responsible for language primarily, language and behavioral inhibition. So what happens for a patient with frontotemporal dementia is they can't find the word, but they still know what the word is. And when you can't find a word, but you know what it is, how do you think that makes you feel?
Wow.
Frustrated, agitated, very upset, right? So a lot of times the frontotemporal patients are behaviorally more challenging to work with. Also, that frontotemporal lobe is where, frontal lobe in particular, is where our behavioral inhibition apparatus is. And so with FTD patients, they can be a little bit more aggressive because the mechanism that would prevent that behavior is impaired more quickly and sooner in the process. So these are patients that often have inappropriate sexual behaviors, inappropriate touching, inappropriate hitting, things like that. So they can be much more of a stressor for family caregivers. And it requires a different level of planning, honestly, than a patient with Alzheimer's disease. And then Lewy body dementia actually has become a little bit more well known because of Robin Williams. Robin Williams had undiagnosed Lewy body dementia. But it's also very different from frontotemporal dementia and Alzheimer's. It's much more neurologically focused. So you have problems with balance, problems with gait, problems with walking. You have significant sleep hygiene issues, night terrors. So also just sort of like what's the word that I'm looking for? See, here's where my age is catching up with me a little bit. It's sight, distance, and perception issues. In terms of, where is my body in relationship to a chair, right? So planning to care for a person with Lewy body dementia, very different than Alzheimer's type dementia because it's much more physically strenuous to care for a patient with Lewy body dementia because you're having to be more of a standby assist. Whereas Alzheimer's type dementia patients, they generally are physically pretty well up until the late stages. So they're walking, they're moving, they're generally physically healthy. So it's just a completely different approach to care, which is why knowing what's causing the dementia is pretty important in terms of planning and also treatment. Okay, so the components then of a memory evaluation to determine, what type of dementia potentially do I have or does my loved one have? It's not just a memory test. I want you to hear that. It's not just a memory exam. It's more comprehensive. It includes clinical history, physical and neurological examinations, PET scans, and other imaging evaluations, lab tests, and then a neuropsychological assessment typically. And all of those evaluations in combination give us a much fuller picture, right, to understand the type of dementia that we are potentially working with. Now, Alzheimer, as I mentioned, there are new technology, biomarker technology, and also imaging technology. We have an Amyvid scan now, which can scan and see an abnormal buildup of amyloid plaque in the brain, which is the hallmark pathology of Alzheimer's disease. So we can now, it used to be if you had a diagnosis of Alzheimer's disease, it was a tentative diagnosis based on symptoms. Now we can give a definitive diagnosis of Alzheimer's type dementia using the Amyvid scan, which is helpful. I mean, sadly, my stepmom, who is 66, was just diagnosed with Alzheimer's disease. And at first we thought it could be something else. Maybe it's, she was an alcoholic for a long time. Maybe it's some other neurological issue, but the Amyvid scan basically, I'm losing the word again. Maybe I'm on my way, who knows? But it solidified the diagnosis is what I'm trying to say. So just know what I want you to hear in that story is oftentimes you'll go in and meet with your primary care physician and you'll say to the primary care physician, you know, I'm really starting to think that I'm having problems with my memory. And the primary care physician is likely going to administer a mini mental status exam. And they're going to ask you several questions like, what's your name? What day is it? What season of the year is it? I'm going to give you 3 words: apple, pen, and cat. I want you to remember those 3 words. I'm going to ask you in 2 minutes to repeat them to me. I want you to count back by 7, starting at 100, right? I want you to spell the word world backwards. Excuse me. So that's a highly sensitive assessment to describe a patient as having dementia-like symptoms. It's highly sensitive. But we still have the question of what's causing it. I don't want you to forget that. So the assessment can help you. Yes, maybe you have dementia, but that doesn't tell you what's causing it. And it could be that you're dehydrated that day. It could be that you had a lack of sleep that day. It could be that your medications are creating a storm of memory challenges. So I just want you to keep that in mind. I have rehearsed that and reinforced that. I think I'll keep doing it too. So what is the #1 risk factor for developing dementia? The #1 risk factor is age. And the older we get, the more risk we accrue. Okay. So 62 and above, about 12% of that population has some form of dementia. You hit 74 and above, we're looking at about 18%. You hit 80 and above, we're right around 40% of 80 and above have some form of dementia. Now, if you get to 85, if you make it to 85 and you have not developed a formal dementia, you likely will not, because whatever has been protecting you will likely continue to protect you. Okay, so that's good news. But I'm going to give you some more good news. Okay, if 40% of 80-year-olds have some form of dementia, what else does that mean?
60% don't.
That's it. 60% don't. And so if 60% don't, we want to know, well, what did those who don't do? Right? What did they do? And so epidemiologists have been studying that for the last, 30 plus years, and they've figured it out, right? What these folks, well, it's not necessarily a direct link, it's correlational, right? But what does the correlational data tell us about 80-year-olds who don't have dementia? Well, it tells us a lot. It tells us that, by the way, this is wow, today I'm really struggling for words. You see that?
Some water.
I know. Is it water or lack of sleep? So I had food poisoning for the last 2.5 days. Started on Monday. So I think I may be dehydrated. This is a collage, folks. That's the word. You know that thing with the faces on it, mixed together. Okay. Apparently I don't have dementia yet. So anyway, here's a collage of famous folks that have been diagnosed with Alzheimer's type dementia. This is the first patient, Augusta Dieter, who was diagnosed with dementia, diagnosed with Alzheimer's disease in 1906. And this is a picture on the left of Dr. Alzheimer, who essentially, Augusta Dieter was admitted into Dr. Alzheimer's clinic, psychiatric clinic, because she was exhibiting signs of schizophrenia. But as Dr. Alzheimer was observing her over time, he noticed that the schizophrenia symptoms were unstable, that something else was happening, right? Because not only was she losing her mind, she was also physically deteriorating as well. And so at autopsy, upon death, Dr. Alzheimer performed an autopsy on Augusta Dieter and identified the pathology. I guess I don't have a picture. Here it is. Identified the pathology of Alzheimer's disease, which is essentially the abnormal buildup of amyloid plaques and the cellular death resulting from those plaques, which are called neurofibrillary tangles. You can see here on the slide on the left is a normal, healthy brain, which essentially weighs about 3 pounds. And you see below that normal, healthy brain tissue. On the right, you see a brain ravaged by Alzheimer's disease. That brain on the right weighs about 1 pound. So it loses, over the progression of the disease, it loses about 2/3 of its mass. So it's highly atrophied. And below that, you can see the abnormal buildup of amyloid plaque. And essentially, what that does, if you can imagine your brain as a circuit board, right? It's electrical impulses moving from point A to point B. But if that impulse hits a sticky mucus-like substance, right, it's going to get stuck and rerouted. But as much as that happens, right, because I can give you an example. So we can think of it like a highway system. If I wanted to get from here to downtown LA, I'm going to jump on, what is this, Sepulveda PCH. I'm going to jump on PCH. I'm going to go to the 110, and I'm going to go up the 110 to downtown LA. But let's imagine that there are all these detours, and the detours symbolize, right, the amyloid plaque. It's stopping me from getting to where I want to go. So I have to go around it to get to downtown LA. Eventually, though, all of the roads are going to be closed. There will be no road to downtown LA. Now, I had a client, I use this example a lot. He was trying to get his belt off, and he was in the moderate stage of Alzheimer's disease. Pretty still high functioning, able to dress himself mostly, he needed assistance picking out his clothes, maybe a little assistance getting into his pants and jacket or whatever it happened to be. And at one point he's trying to get his belt off, and he can't figure out, using his own dexterity, how to do it. So the road to taking off my belt was permanently closed. But there were other roads taking my belt off appropriately. There were other roads that he could still use. And so what he ended up doing is he cut the belt off with scissors. Okay, so he still could figure it out, but it wasn't in a way that was necessarily appropriate. Did you have a question? 5 minutes until I'm done? Are you serious? Holy schmoly. Have I been talking forever? I just like to talk. How is that? I just like to talk. I'll just take 10 minutes. Yeah, I'll finish up in 10 minutes. Because you got the basic of what we're trying to do. What is the difference between normal aging and Alzheimer's disease, right? So you got that information. So essentially you can see here that, everything stops because the brain is responsible for everything, right? That as it atrophies, then everything is impaired. And how do most patients with Alzheimer's disease die, right? So as the brain moves from the top part of the brain, which is the human part of the brain responsible for human functions, language, reasoning, strategizing, problem solving, living in community together, things like this. It moves into the mammalian brain, which is feelings, emotions, behaviors, and long-term memory. And then it moves finally into the brainstem, which is automatic functioning, right? Blood pressure, swallowing, standing up, having balance, things of this nature, right? So most patients with Alzheimer's disease, they become non-ambulatory, right? So they're no longer able to walk. They stop eating because they're no longer able to swallow. And they generally die from pneumonia, right? From aspiration, because they're no longer able to cough fluid out of their lungs. Those automatic functions, and that's the level, right? That's the acuity of the atrophy. And that's what happens generally. And it's very sad. So I'm not going to talk too much about the plaques. Just know that it's the amyloid plaque buildup that causes the cellular death. But we still haven't really found, that's what this all looks like, right? And you can see the movement over time. And as I mentioned, Alzheimer's disease, it's generally 8 to 10 years, but it can be, that's on average. It can be much longer than that. It can also be shorter than that. Okay, I'm going to very quickly talk to you about medication. What I need you to know, please know this, that the acetylcholinesterase inhibitors that are on the market, those are the longest provided medications on the market. That's things like Aricept, for instance, or Exelon, or Donanzapil. Okay, that's the generic name. They do not slow the progression of the disease down. I want you to hear that and understand that. It does not slow the progression of the disease down. What it offers is a symptomatic benefit. So you can think about this very similarly to flu medication. If you have the flu, you have the flu, and you have specific symptoms, correct? If you take flu medication, what happens to those symptoms?
They ease.
They ease, that's right. And if you don't take the medication after 6 to 8 hours, again, what happens to those symptoms? They come back, right? So the medication, the acetylcholinesterase inhibitors like Exelon, Aricept, and Donanzapil, they are just like flu medication. They are helping the symptoms, but not slowing the progression. Okay. The same principle applies to memantine or Namenda. But there is a new medication on the market called lecanemab. And lecanemab you probably have heard a lot about. This is an intravenous medication. And it has been shown barely to slow the progression of the disease down if it's administered soon enough in the very early stages or even maybe in mild cognitive impairment. There also are significant side effects. My stepmom would have been a candidate for this medication, but the significant side effect is brain bleeding. So please be sure that you talk with your doctor, and it's, you know, all medications have side effects, but that's a pretty significant one. It's also not yet covered by Medicare, and it's costly. Okay, so just something, but I think for, you know, families who want to do what they can do, it's, you know, it's what resources do you have, and also what's your threshold for managing maybe some of those side effects. I also want you to know that depression, particularly for older adults, can often have dementia-like symptoms, lack of ability to concentrate, highly distracted, memory challenges, right? Executive functioning impairment. So depression is a common experience for older adults with the amount of grief and loss that we experience. So it's just something to consider. If you're feeling hopeless, if you're feeling sad, if you're feeling sort of lack of motivation, You're not feeling, sense of joy in activities that you once found sense of joy in. If you're eating too much, not eating enough, sleeping too much, not sleeping enough, having thoughts of hurting yourself or bowing out early, I really encourage you to talk to somebody that you trust. If you're also experiencing memory challenges, that might be one of the reasons why. So I just want you to consider that. So treatment for dementia, you want to have this diagnostic evaluation that I talked to you about, potentially medications, educating yourself, and I offer educational courses that you can attend. I can also do one here if that would be helpful. Psychosocial interventions like counseling, which is what I offer. And then recommendations for caregivers, there's so many, but most importantly, respite. You have to have time for yourself. And there's so much evidence to support, how plugging in ways that are meaningful to you. I know for me, how do I plug in? I take walks on the beach, so important, right? I practice yoga. I meditate every day. I go to temple once a week generally. I love to hike. I love to swim when I can. I love saunas and sweating out my stress. I have a pretty stressful job. And so I need to do a lot to take care of my own well-being. So I encourage you to think about how to do that for yourself as well. But even an hour, even 30 minutes, even 10 minutes matters. It matters. So just don't give up on yourself. Don't give up on yourself. And then I'm from Always Best Care. This is my family's company. We've been in business for 15 years. We've been here in Torrance. I cannot even believe it. And we offer all sorts of community resources. Our bread and butter is offering home care. So providing caregivers at home for older adults and folks that need us. But we also help families find assisted living communities. We offer counseling. I'm the counselor. Here I am. We also do community health programs like this one, and just happy to be of service and happy to take our very traumatic experience with our own family and pay our lessons forward. So just know that that's what we're here to do. And I'm happy to take any questions that you have, if there are questions here in this room or also in the chat.
Wonderful. For those online, feel free to put the questions into the chat, or you can also unmute yourself and I can call on you. Are there any questions in person? Yes,
Yeah.
go ahead.
What is the scan for Alzheimer's?
It's called Amavid, AMAVID, Amavid.
AMAVID?
Uh-huh.
And is it a type of X-ray?
It's a PET scan. Yep.
So it's also known as a PET scan.
It's also, yes. So it will take an image of the brain. They'll shoot some dye in there and that will help to observe the amyloid plaque.
Okay. Do you know if when that's done, is the patient put under a local or it's awake?
I believe so. Yeah.
Repeat that question for the people online.
The question was, what is the scan that identifies the amyloid plaque in the brain? It's called the Amavid scan, AMAVID.
And you're awake.
I'm pretty sure you're awake, but I don't know. Yes, you would be awake, I believe. Yeah.
Yes.
Yep.
So the old word senility,
Uh-huh.
what does that, how does that relate to what you just talked about? With Alzheimer's and dementia and all those different.
It's been replaced. We don't use that
Don't
word
even
anymore.
use it
Yeah, we
anymore.
don't use that word anymore.
Word of the past.
Word of the past.
Just for the online people.
Senility. Yeah, senility. It's not a word that we're using anymore. I don't even believe it's in the DSM anymore. Dementia is in the DSM. Yeah.
Are there any questions online? Wonderful. Well, not to put you on the spot, Dr. Hart,
Yes.
but do you remember the 4 names?
Oh, yes.
No, it's okay. I'm kidding.
Yes, no,
Okay.
I want to do this. I'm starting to sweat, but All right. So Agnes, Elna,
Yeah.
Elavia, and Ron.
Woo! Wonderful.
So hey, I was able to transition that information from my working memory to my short-term memory bank using a specific strategy, primarily concentration, and then I used rehearsal and repetition.
Wonderful. I apologize.
No, I appreciate that. Yeah, I appreciate that.
Show that it works.
Yes,
Okay.
it works. It works.
We had two more questions if you have time.
Sure. Yeah.
The first is, can you rephrase or reshare the frontal dementia stages?
The frontotemporal
Temporal
dementia stages. I don't know stages. So for Alzheimer's disease, there can be up to 7 stages. I usually use 3 stages, early, moderate, late. But for frontotemporal dementia, I think what I shared is that generally the disease progression is 4 to 6 years.
Okay.
I think that's what you were referencing.
Okay. Yes, that is.
Okay, that's what,
that
okay.
was. And then there's a question, what was the correlation? Blanca, if you're able to clarify, maybe it was when you were naming people. Were you talking about correlation then?
I remember using the word correlation.
He was gonna tell us the correlation between the ones that did not have Alzheimer's, like something he was gonna mention it.
Oh, okay. So so the 60% is the question that you have, right? And what do they do? So what were they able to do? And it goes back to that 4-pronged approach that I started with. It's diet, it's Mediterranean style diet specifically. And so we know, there's a lot of now conflicting evidence on the agency of blue zones, the efficacy of blue zones around the world. But, that's good research, is like questioning data points and findings. But based on, the current understanding, there are these blue zones around the world where people live longer with limited disability. And what is it that they're doing? And also, when we would expect, 40% of 80-year-olds to have some form of dementia, we're looking at in the teens, right? We're looking at 18%, 19%, or even lower. So what are they doing? They're eating a Mediterranean style diet. And there's tons of information out there, but essentially, if you want to eat Mediterranean style diet, you're eating lots of greens, right? Fruits, vegetables, legumes, fish, basically for the omega-3 fatty acids, and then olive oils, right? And what are you reducing? Well, you're essentially not eating the American style diet, right? Which is the SAD diet. So you're limiting sugar, you're limiting red meat, and you're limiting processed carbohydrates. If you can shop on the perimeter of a supermarket, that's essentially where you want to stay. That's where you can get the foods. They're whole foods, plant-based foods, non-processed foods. Just take the process out of it. You want 1, 2, 3 ingredients. If there's 20 ingredients in the food that you're eating, it's not food. It's really not. It's something that a chemist made in a laboratory. That's not what you want. So it's diet. And by the way, I'm not judging. I don't want to ever come off as I'm like proselytizing. What I want you to hear is any shift that we can make in terms of harm reduction, what we can do to limit the harm to our bodies, to our planet, to our neighbors, right? I think that's something we can all do, but it doesn't have to be an all or nothing proposition. I think can be maybe you take 1 meal or 2 meals a week and it's just veg, right? Only vegetables, no meat. See what happens. Okay, so diet, movement of your body, generally speaking, 10,000 steps a day or more, but not all of us can do that. So I think it's a commitment to moving our body in some meaningful way. Social connectivity, staying connected to others and engaging with others. And then cognitive fitness. So learning something new or doing something old in a new way. This could be as simple as brushing your teeth with your non-dominant hand, for instance. Doing something old in a new way or learning something new, just understand it needs to progressively get harder.
Wonderful, thank you. It's beautiful.
Wonderful. Thank you so much for sharing that, Dr. Hart. And we appreciate your time.
There.
Hello. Want to thank you again and everyone for joining us.